Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chew Man Chew, and I'm with my great friends, Dr. Avram Rago and Dr. Sam Mather. Hey, guys.
How's it going?
What's up?
We have a wonderful guest tonight, Dr. Ryan Rochat, to discuss congenital syphilis. But first, Sam, remind us what our show is all about.
I would love to. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Ryan Rochat. Dr. Rochat is an assistant professor of pediatrics in the Division of Pediatric Infectious Disease at the Baylor College of Medicine. He also directs the Biomedical Informatics dual degree program and oversees the bioinformatics thread in the foundation modules for the medical school curriculum. With a keen interest in bioinformatics, Dr. Rochat has an interest in the progression of congenital infections throughout childhood, as well as real-world costs associated with these conditions. His expertise in informatics has been pivotal in addressing congenital syphilis, a neglected disease with rising cases in Texas. Observing care gaps in follow-up care for these infants, Dr. Rochat established a clinic in 2022 dedicated to congenital syphilis, where he centralizes the care of affected children. This clinic aims to provide excellence in patient care and serves as a valuable resource for healthcare providers, the community, and local health departments. By normalizing the evaluation and management of congenital syphilis within the centralized clinic, Dr. Rochat hopes to better understand the epidemiology of infection and improve treatment and follow-up efforts to address this ongoing issue. Dr. Rochat teaches us how to make sense of all the different types of syphilis testing, why penicillin is still so effective, and how often we should be following up our infants with congenital infection.
Avram, you think our listeners will enjoy our discussion?
Yeah, don't be trepping. We've got just the tips for you.
We've done better, we've done worse.
It was great. It's perfect. Dr. Rochat, thanks for coming on the show.
Yeah, absolutely. Thank you for having me.
Because we're an informal group, is it okay if I call you by your first name? Is it Ryan?
Certainly. I generally go by that. Yes.
Excellent. Excellent. All right. So we have a couple of rapid fire questions just to sort of get to know you. My first one is, can you give us a little bit something about yourself, a couple sentences, maybe about who you are, what you do, and maybe something outside of medicine that you like to do?
Yeah. I'll say probably the best way to describe myself is going to be everything outside of medicine. And I say that because, our neighbors, pretty much anyone who knows me goes, "You're a Renaissance man." And I always thought what that meant was they're like just trying to call me old, but be nice about it. But really what I take it to mean is I jokingly say I'm a jack of all trades and I'm a king of none. It's like, I love listening to music, but if I'm going to do it, I'm listening to vinyl, and I have a complete obsessive compulsive vinyl setup. I love cooking. I love making pasta. But I'm going to do it with an extruder, and I'm going to make sure that when it's extruded that I've checked the humidity. This probably sounds like I might have a condition or something. But everything has to be right. And it goes on with a bunch of stuff, coffee, espresso. I love making my own espresso. I'm really into photography and doing film photography, but digital. So there's a lot of stuff that I like to do. But what my wife often says is, I will pick up something and just pretty much do it and make it my own. Yard work, car work, it's it. So there are very few things that I'm not interested in. And the problem is I'm passionate about a lot of stuff. But one of these is actually syphilis and congenital syphilis, which is probably why I'm here talking to you guys, but also, why I ended up starting a clinic to help take care of and, serve this community and this group of patients.
Nice. Ryan, you'll be our first guest when we break off and do non-medical podcasts, just like medical people who do everything else.
Spend a lot of time doing it.
The Side Hustle podcast. the Siders. Oh, yeah. We'll come up with a better name.
Yeah, I feel like I've learned a lot from my failures in medicine in my early career. Anything that stuck out with you that anything you've learned from throughout your training or throughout your career?
Yeah, and to be honest, I'll give two failures. One failing in like the greater realm of my time, which is in other things I do like cooking. But then the other one actually is related to when I was getting my PhD. And so I'll say the first failure, and the reason why I like the failures, my family loves when I cook. And the problem is that I cook for them all the time, but when you screw up, they will let you know. And your taste buds are actually pretty sensitive, so you can tell whenever you've ruined things. And, my mom used to always tell me, right, in a sense it's true, like never make something for the first time with guests. Always make it before. And, I remember my mother-in-law was in and I was going to make fresh pasta for the first time, and it was an absolute disaster. Like complete disaster. And I was so upset and so mad. My wife is like, well, what do you expect? Like, you've never made pasta in your life. Why do you think you're going to do it right? And it was one of these things where I was going back through and I was like, oh man, it didn't go. And I'm like looking at this and the humidity's all off. And really what it all boiled down to is I just forgot to tear the scale. And so I was completely off, like a magnitude is what it was. Yeah. So it teaches you a little bit, right? That sometimes it's your tool, not necessarily you. The serious one actually comes from when I was getting my PhD, and my PhD was in structural computational biology and molecular biophysics. That is a mouthful, but exactly way over the head. But what it was, and it's funny actually, how I got into the lab was I forgot to turn in paperwork. And when you didn't turn in paperwork, you had to rotate in the program director's lab. And there was nothing I wanted to do less than that. And so I got in trouble. I had to rotate in his lab, and within 1 week, I fell in love. And what it was he did electron cryomicroscopy. So those beautiful three-dimensional pictures of viruses that you see, I made those. And essentially the way that it works is you get images of the virus, and much like a CT scanner, right? You take a whole bunch of images of something in a circle, and then you can recreate a three-dimensional volume, except for we were doing this with something that was, smaller than the wavelength of light. These are... 1,200, like 120 nanometer virus particles. And one thing that we were doing, and my interest was, I was very interested, I studied herpes simplex virus. And so I wanted to figure out how DNA actually got into the virus. And I got to go to Japan. We got to use this brand new microscope that had very, very high contrast. It was unique for looking at this, essentially what's called a portal. It's how DNA gets in. So we did it. We did our reconstruction. And what happened was we found that this thing, which was theorized to sit on the outside of the viral particle, was actually on the inside. And the reason why that was groundbreaking was, because that's how it is for every single other virus that there is. So this wasn't big news, but everyone else had said it shouldn't sit there. So we tried to publish our results, and we submitted this, and we submitted it for peer review, and it came back and just across the board, no. It's not, no. Can't be published. Why? Because the portal's on the outside. And my mentor at the time was like, well, Ryan, what do you want to do? And I was full, I don't know. I'll put it this way. I sort of shot back and said, I think I'm right. And so I wrote back this really long, detailed thing. I said, look, every other attempt to find this was indirect. And I think I said something along the lines of absence of evidence is not evidence of absence. And I pushed back and said, send it out to another review, because this is, in a way, it's almost irrefutable. It's like, if you were to do a CT of someone's chest and see a gigantic mass there, and you go, it's nothing, it's artifact. It's not artifact, it's real. And so, lo and behold, went back, and they then reaccepted the paper with no changes and put it on the cover of the journal because they felt it was that impactful. And so, right, in a sense, it's a failure because I did fail completely. It was rejected straight up with one of the first papers. It was supposed to be my seminal work, but it taught me a little bit that, sometimes you push, when you believe in something, push back, stand up for your research, stand up for your work. And look at that. It actually worked. To be honest, I don't do that anymore. I'm like, oh man, I'll just submit it somewhere else. It's so much easier. Not worth my time. Not worth my time to fight them about it. But yeah, so that's probably a failure that had a good end to it.
That's awesome. It sort of reminds me a little bit, like what we do here on the podcast, we bring people on, we talk about evidence-based medicine and what we know in the literature, and try to push back on even some myths that we have that we hear about. It sort of reminds me of, back when they were like, H. pylori, that can't cause ulcers or something like that. He was like, no, this is like, these are, or even some of we have a series called Things We Do for No Reason that we serve from the Journal of Hospital Medicine. These are things that no, if we find there's evidence elsewhere, like this is how we should be practicing. So
yeah. And I'm sure, I think I get into it. I think I'll probably get into it because whenever I talk about syphilis, I end up saying this, but this even holds true with the management of syphilis, where when you look at it, the CDC recommendations, when you read through like the long document, you get to a line where it says, everything that we're saying is based upon expert opinion. There are no randomized controlled trials. And you're like, oh, okay. So it's amazing how much we do, but some, that I think that there's value in gestalt whenever you've seen something and done something for a while.
Yeah. And this is going to be a teaser for everybody as we come up next and talk about syphilis. It sounds like we're going to talk a lot about these guidelines and what things are on it and what we can take from it. I will ask you one more question, Ryan, before we get into a case, if that's okay.
Yes.
Best advice. We love hearing that on this show, both as a learner, as a teacher, anywhere in your career. What do you think you got and what can we pass on to our listeners here?
Yeah, I will say, and again, this is the problem whenever I go and I talk. Two things, right? You say, give me one, two. Maybe I'd be a politician. I don't know. But
Buy one, get one.
Exactly. BOGO. The one that I learned, which drove me insane during fellowship, is this idea of just saying, I don't know, right? When you come up with something, you don't know what it is. As a fellow, it was very frustrating. But when I started practicing on my own, and I joke, like I'm never practicing on my own, right? If I come across some weird viral thing, I lean my head out the window. I'm like, Gail, what should I do? Or if it's tuberculosis, I'm like, Jeff, what am I supposed to do? So I'm never really practicing alone. But what I did realize is that there's so many times we just don't know. And congenital syphilis is one of those things where when we talk about it is you just don't know. It's rarely yes you have it, and it's never no you don't. It's probabilistic, and so that really did help me quite a bit. And then I'll say probably the more pragmatic bit of advice here was what I got as a teacher, and this is not, I'm not being immodest, and I'm also not trying to be self-deprecating. I get sought out a lot because I also do a lot of biomedical informatics and clinical informatics. So this is growing very, very quickly. And the hard part with this is I get asked to do a whole bunch of things. I get asked to bring in and do this. Hey, Ryan, what's your advice? What's this? And one of my colleagues who literally sits in an office right next to me told me, he goes, Ryan, you are the only person who will say no for yourself. You better start practicing. And again, right, this is an odd statement when you're trying to, grow, you're trying to grow the crowd of people you want to talk to. But that's also juxtaposed with my mentor who said, Ryan, you need to spread mustard seeds early in your career because you don't know what's going to grow. But then what she said is she's like, but at the end of the day, you have to tend to the plants and you have to be able to say no because you can't have it running wild. And if you plant enough seeds, so in that sense, I would say best advice, you're the only person who will say no for yourself.
Yeah.
And just because you say no does not mean that you're being dismissive. Maybe you're saying no because you need time for yourself. Maybe you just need time to focus on the things that are important to you.
And we're starting to get a little bit that as a theme as we start to ask some of these questions, as we start to talk about what medicine is like for everybody as they've moving farther into career. This time that's post 2020, getting a lot of these conversations, which I think is really, really valuable, and for our listeners to hear this as well. So thank you. We've been chatting for a little bit. I think it's time that we get into a case because we have a lot to talk about. Avram, would you mind taking us away? And by the way, I love the name of this patient. If you've ever listened to a heart murmur and thought, did I really hear that? You're not alone. I've had moments in the wards where I thought I caught something subtle, maybe a faint gallop or an irregular rhythm, but with background noise, a restless patient, and no time for a second opinion, I had to move on. That's where Echo Health came in to help me. Being able to record the sound meant I could revisit it later, and with the help of Echo's AI, I got confirmation that what I heard wasn't just in my head. It's like having a second set of expert ears even after you've left the room. So Echo combines the stethoscope you already know with enhanced audio and advanced AI to help you detect heart and lung conditions earlier and with more confidence. With Echo, you can hear with precision, even in noisy environments. Echo's digital stethoscope amplifies heart and lung sounds up to 40 times, and noise cancellation cuts out distractions. You can also detect disease earlier, unlock murmur and AFib detection powered by Echo AI, along with sound recording, sharing, and more for earlier diagnoses and seamless collaboration. Lastly, it improves diagnostic accuracy. Backed by 4 million heart sounds and 8 FDA clearances for devices and AI algorithms, those who use Echo are 2 times more likely to detect heart disease. And lastly, a personal benefit, teaching. I've used Echo recordings to walk learners through abnormal heart and lung sounds, and even to help patients better understand what's going on with their own bodies. It turns the stethoscope from a black box into a real-time teaching tool. So we trust Echo so much that we worked with their team to create a special offer just for our listeners. Right now, you can get $50 off plus a free customizable chest piece cover at echohealth.com/Cribsiders. Your purchase is HSA and FSA eligible and may qualify for CME reimbursement. Plus, Echo guarantees you'll detect heart and lung conditions more confidently. If you don't, return it for a full refund. Go to echohealth.com/Cribsiders for $50 off, plus a free chest piece cover. That's EKOHealth.com/Cribsiders.
Yeah, so we have Penny G. She's a 31-year-old Gravida 2 Para 1 pregnant woman with no significant past medical history who presents to establish routine prenatal care at 10 weeks gestation. She's not had any symptoms and states the pregnancy is going well. Her OB-GYN screens her for syphilis based on the Centers for Disease Control and Prevention Sexually Transmitted Infection Treatment Guidelines. Her rapid plasma reagent is positive with a 1 to 8 titer. She denies previous syphilis infection. So Ryan, for us, could you describe the rationale for screening for syphilis in pregnancy and when the screening should be performed?
Yeah, and the main reason is because in utero transmission of, and if you hear me say syphilis or you hear me say treponema pallidum, I mean the same thing. I won't, use morbus gallicus or, luz venerea or any of those weird ones. But, the reason for it is it can transmit during any stage of syphilis. It can transmit during early primary, early secondary, early latent, late latent. And it's just that it's a higher rate of transmission whenever it's early primary, early secondary. And the reason why it's important to screen and why you do screen is because treatment is tremendously effective at reducing the risk of vertical transmission. And so you aren't going to know to treat unless you screen. And slight caveat on that is just because you do give treatment during pregnancy does not mean that you completely eradicate any chance that a child is going to have congenital syphilis. And so, it comes up a lot because when you look at, when do you screen? In Texas, it is mandated by law. You screen at your first prenatal visit, you screen in 3rd trimester, and you screen at birth by law mandated. And, the ACOG recently changed, and I'll read exactly what they said. They said, in the context of rapidly increasing rates of congenital syphilis, OB-GYN and other obstetric care professionals should screen all pregnant individuals serologically for syphilis at the first prenatal care, followed by universal rescreening during the 3rd trimester and at birth rather than a risk-based approach. Verbatim, that is what they said. You might go, oh, well, cool. This is what Texas does. That's where I'm from. Texas does this. But recently I've talked with other people and they go, oh, well, we do the same thing. And I was like, really? You do? Because I didn't think that you didn't. They're like, yeah, no, here it is. They sent me their law. And one of them said that providers should take all necessary steps to offer syphilis testing at these points in time. And so I went back. I was like, okay, so is there a difference between offering testing and mandating testing? And the person goes, I never thought about it like that, but yeah. And perhaps I'm a little cynical, but my experiences in these areas are I have a lot of patients who come to me and they have no idea why they're there and they have no idea that they were treated for syphilis. So just because you offer something and I say, oh, hey, ma'am, look, they tell us that you need to get screened for syphilis, but you can't have syphilis. So I'm a little cynical about that.
So one question I have is, so we just talked about when we should be screening and, maybe whether, who is telling us that we should be or should be at least offering. Can you talk to us a little bit about the test that was ordered here, the rapid plasma reantigen or region that was here? Or I've also heard of VRDL, which stands for Venereal Diseases
Research Laboratory.
Which I had an attending once tell me was the full name was on their boards, and he didn't know what that meant. And so I've always remembered what VRDL sort of stood for afterwards.
Yeah. And
High yield.
Yeah. So yes. So that first test, the rapid plasma reagent. And so, anyone who would take that down, we go, okay, so rapid, so it's quick. Plasma, okay, so it's from plasma, and it's reagent. What's reagent? And so you have to go back. You have to turn back the clock a little bit to 1906. August von Wassermann of the Wassermann test and of Wassermann cards, that in some states you used to have to present your Wassermann card to the county clerk in order to get married, to prove that you did not have a positive Wassermann test. What Wassermann identified in the patients, in the blood of patients with syphilis, was that they had something in their blood that he called reagent. That's what it was. We know it's now cardiolipin, all kinds of other proteins that are in blood vessels. That's what we know now. We called it reagent. So the Wassermann test detected reagent. And then, the early 50s, someone went, man, this Wassermann thing takes too long. We need a rapid plasma version of it. And the reason why the Wassermann test was revolutionary at the time was because around this time, darkfield was the mainstay. But with darkfield examination, you needed to have a lesion, which means you needed to catch someone with early primary or early secondary and had a lesion and something that you could get at. Because if you didn't have that, you would have no way of knowing whether or not this person had a history of syphilis, which is where the treponemal tests come in. And so a roundabout way is the rapid plasma reagent is essentially a quick way of doing something that was invented in 1906 that we then improved in 1950, and we still use it now. But what's great about it is a way of telling you how much you have. And so it becomes a great marker for monitoring treatment. If someone shows up, and so, the Penny G came in here and she's 1 to 8. If she gets treatment, I expect that to go down. What I mean by go down is I expect that to go from 1 to 8 to 1 to 4 to 1 to 2. And what that number is it's a dilution. And so when you're 1 to 2, it means they can dilute your blood twice and still see evidence of infection. But if they dilute it 4 times, they can't pick it up anymore. 1 to 128 means they have to dilute your blood 128 times. So you want to see that dilution come down. And so that's why it's valuable in these scenarios, because you go, hey, it looks like the treatment is working.
And so just to talk a little bit about the RPR, what's the sensitivity of the test, and why do we use that to start with instead of the treponemal antibody that we can run these days?
It depends on if you want to get into a fight, Sam.
All right. That's what I like to do early in the episode.
Exciting words.
And I say it right because, wars could have probably been started over the forward algorithm or the reverse algorithm. And this is where it comes up. So the RPR is what starts the reverse algorithm. And so that one starts rapid plasma reagent, you start there. And if you see a positive RPR, you go, ooh, I'm concerned that you may have syphilis. But the problem with a positive RPR is that if you have lupus, or you have an autoimmune disease, or you have herpes, or you have EBV, or you have tuberculosis, or you have malaria, and the list goes on and on and on and on and on, can cause a false positive with the RPR. But the value in the RPR is that it is quite sensitive, right? And again, hopefully it's not lost upon the people listening to this. If you're screening someone, you want to have a sensitive test. The problem is you don't want it to stop there. And so in the forward algorithm, you do an RPR. If it's positive, you go ahead and you do the true treponemal test, which is your confirmatory. And you'll hear the terms, the TPEIA, which is a treponema pallidum enzyme-linked immunoassay, a TPCIA, a treponema pallidum chemiluminescent assay. And then you'll hear one, an FTA-ABS. So it's a fluorescent treponemal antibody test. That test is from 1957-ish. But then the TPPA, which is another treponemal test, is actually from the early 60s as well. So you have all these varieties of tests, but what they're meant to give you is a confirmation, because they're very, very specific for treponemal infection. And not to really go down a rabbit hole, when I say that they are specific for it, there are unique cases. If you look in UpToDate, you look at Redbook, you look at the CDC, they'll mention Yaws, they'll mention Behel, they'll mention Pinta can cause some treponemal tests to be positive. But the reason why people like an RPR is because it's pretty cheap, it's pretty quick, and it can give you an idea, do I need to do something about this? But ultimately, it's going to give you a number to track. Because with the treponemal test, since that says, has this patient ever had syphilis before? Well, if they had syphilis 5 years ago, they'll test positive for it now. So that it doesn't help you in that sense, because you want to monitor that treatment. And then, Sam, to get over the reverse, the reason why some people like the reverse screening algorithm is because when you look at the CDC guidelines or the Red Book guidelines, they say, essentially, has this mother ever had a history of syphilis? And that's simple. That's a treponemal test. It's not an RPR, because if someone had a history of syphilis and was treated and had a perfect response, their RPR may be non-reactive, right? So it doesn't answer that question. Here's the other thing. If you have overwhelming infection, your RPR may be negative. It's called the prozone infection. If you had a history of syphilis more than 2 to 3 years, upwards of 40 to 50% of people can seroreverts. That means Ryan, I'm going to call this on myself. Ryan gets syphilis 5 years ago, never got tested, never picked up on any of the symptoms. He thought that the rash and the fever was COVID, but it was actually syphilis. 5 years later, he gets screened. About 40% of people can serorevert, meaning their RPR will be negative. But Ryan's had syphilis and he hadn't been treated. And to quote Vitus Vitius from 1565, the pox may well agree a truce with the patient, but it never signs the treaty. And so they knew in the 16th century that if you don't treat syphilis, it will come back and it will get you. And that's like the classic tertiary neurosyphilis that we hear about. So the RPR is really, really sensitive, but it's not the end of it. And in pregnancy, the reason why I see people really, really push it is because it does give you that number, right? You want to know if you want mom's titer or you want the birthing parent's titer to come down. Because if you treat that person and that titer goes up, your treatment didn't work. And then that baby is at higher risk.
So when you're looking at the treponemal tests, is it center dependence or is it treponemal test du jour? How do you pick which one you want to do?
Oh boy. So
maybe that's too big of a question. I don't know.
No. It's not a big question. Without calling out specific labs and specific lab names, every place will have their own testing nomenclature. I'm actually working on a paper to write about this because one of our issues that we had was for about 10-ish years now, maybe a little bit more, our hospital, we got rid of the FTA ABS test because it was really prone to false positives. And you do not want a false positive confirmatory test. You kind of don't. So we had gotten rid of it and we changed all of our nomenclature. And really what we had was we changed everything to syphilis screen is what we called it, or syphilis screen congenital. It's what you ordered when you were in our hospital. That was it. And what that would do is then that would trigger over to do, if you're a baby, and we'll talk about this later, if you're a baby, you really just want to do the RPR. But if you're older, you want to do a treponemal specific test and then get an RPR and then do another confirmatory. And so we changed the names so it was easy for someone to comprehend. But our hospital has 70 affiliated clinics. And so what was happening was if you were in a clinic who was one of our patients and you would go and you would type in syphilis, it would give you RPR with reflex to confirmatory testing. That's perfect. That's exactly what I want. Confirmatory test and an RPR. It does it all for me. And the problem was it was going to the FTA ABS. And in the span of about 3 months, I had 25 false positives when everyone started screening. And so there is a lot in a name. And fortunately or unfortunately, sometimes you're like, well, what test do you want to send? If I say, make sure that you send a TPPA, like if I say that, when you order that in our hospital, you don't, unless someone linked TPPA to that order. So sometimes it means that the provider has to dig a little bit more. And so certain companies, you can look at all the different companies that you can do lab testing through. When you go into their catalog, they may say syphilis screen, and that may just be a TPPA, or their syphilis screen may be an RPR. So it's really hard to give exact advice because you just have to look and see what the test is. But what I can say in general is a lot of people are leaning more towards the reverse screening algorithm, which is a rapid EIA or a rapid CIA that you can get an answer in 15 minutes. That will reflex to a non-treponemal like the RPR. And if the RPR is positive and the treponemal rapid is positive, you have syphilis.
Okay.
And so just to kind of summarize, so we actually talked about both ways, RPR, confirmatory syphilis, or antibody to treponema, or the kind of the other way around that you just mentioned with a rapid version of it. Kind of, it sounds like an antigen antibody type of situation. For the patient who's pregnant, for Penny G here, it sounds like we are still recommending the RPR first, followed by a confirmatory treponema antibody test, which you would recommend be the TPPA. And then we can say this patient likely has syphilis, and we can move forward with kind of our treatment. Does that sound like an appropriate summary for the pregnant patient, or am I missing something?
No. And this is why it's so confusing for a lot of people, because you will see our hospital, if you are pregnant, they will start with a reverse screen. And here's a perfect example why, because I just saw someone in clinic today where she was blown away because she was seen by her provider her entire pregnancy and was never positive until she showed up for delivery. Why? Because her provider did RPRs. And so this was an individual, when I went back and asked, and I was like, you've never heard of she's like, no one's, and she freaked out because she was fine throughout pregnancy. And then when she delivered, everyone lost their mind. And maybe appropriately so. And then when I saw her in clinic, I went back and I asked, and I was like, and she's like, well, they did the RPRs. I was like, have you ever in your life had like a rash on your hands and on the palms of your feet? She's like, 5 years ago, but no one did anything at that time. And I was like, oh, so, and she's like, and I had that and I had some hair loss. Probably syphilis 5 years ago. Well, and how in the world's her RPR negative? Because they can serorevert. And so it's hard to say, because for some people, they do not have the ability to get a reverse screening done. And so what I would caution, the way I would answer the question is, it's completely fine to start your screening with an RPR. It absolutely is. But just understand that if all of a sudden you do a different test at another point in time, it may change. And so it's just having that idea that's there. And don't even get me started on the fact that this is a subjective test. I often joke with people whenever I see them in clinic, and I'm like, what color is the wall over there? And they're like, oh, it's orange. And I'm like, it's awfully orange. And I said, that's the difference between a 1 to 2 RPR and a 1 to 16. And so, right, another thing with the RPR, right, is that since it is subjective, one lab may run it and it's one thing, and another lab may run it and it's another. And I had a kid I was following, and the mom didn't want to come down to our clinic. It's fine. She's like, can we just get the lab drawn at somewhere? Sure, cool. And the person's RPR went from 1 to 2 in our system to 1 to 16. And I brought him back immediately and repeated it, and it was 1 to 1. So there is lab variation. So if you think that this does not cause any problems, it causes all kinds of problems. And so documenting where it was, the lab it was done, is very important for anyone when they're trying to look back through these numbers.
And so just because, you see this a lot, this is kind of my last question about the screener test, I think. Would you, and this is probably a healthcare resources question, et cetera, would you send the RPR and the anti-treponema antibody at the same time when you're screening in pregnancy? Yeah.
And the reason I would say yes, Sam, is because and again, right, in whatever ivory tower I exist, if I do send that, if I send the rapid treponemal screening test and it is positive, it will automatically reflex and do the RPR. And so a lot of places, there's one, I won't mention the place that has it, but there's one called a syphilis cascading antibody reflex. That one essentially does that. It starts with a very rapid turnaround, EIA or CIA. And then if it is positive, it will give you the RPR. If the RPR is positive, you stop, you have syphilis. But if that RPR is negative, maybe your initial screen was a false positive, and then it will send in reflex to a final true confirmatory TPPA.
Yeah. And generally EIAs, we see this all the time, and Lyme, for example, and other things like that, that are they seem very sensitive. Anything that has an inflammatory condition in your body almost sends those positive. So that's usually a pretty sensitive test. Am I correct by assuming that?
Oh, yes. Yes, it is. Okay. And I always tell people, look, if you look at it and you get really confused, me too, So if you're confused, reach out and ask around. And this is one of the main things I get called about a lot of the time. But I lecture, every month I go over and I lecture our interns when they start their newborn rotation, and I get them on the second day that they're there for their month-long rotation to tell them all of this. They get my cell phone, and I get calls intermittently. I tell them, but remember, it is not an emergency. You can call me at 9 in the morning. You don't need to call me at 11 at night. Yeah. But you can text me and I'll answer your question about it. But and again, it comes up a lot. Even after lecturing them, it comes up a lot.
And so I know we spent a lot of time kind of talking about this test and a confirmatory piece, but I actually think it was very helpful for all of us to understand that this is not perfect screening tests. These have their issues. And so therefore it is complicated even for an expert. So we should have all of this in the background as we move forward and kind of go through our next level questions.
Exactly. Right. And the last thing I'll add to is just, so I don't know how many people know of Harry Nilsson, or let alone know of, he did an album called The Point. And it's weird. It was trippy. My parents were like, oh, watch this movie, Ryan. I'm like, what were you guys on? It was like the trippiest thing I've ever seen. I tried to watch it with my son, and I'm like, this is weird. But the long story short, in it, there's a guy who says, the thing is, you see what you want to see and you hear what you want to hear. You dig? And that's what the Rock Man said. And the reason I mention this is because with treponemal testing, what you'll end up finding is people will take the answer that they want. And when there's a lot of confusion around the testing, very few people are going to go, well, one test says I don't have it, and one says I do. I have syphilis. It's not going to happen. So it's very important to consider that when going through a lot of the testing, because people will, not just patients, providers will anchor towards the one that is easiest for them.
So while I guess the diagnosis might be a little bit convoluted at times, to say the least, hopefully the treatment's a little bit more straightforward. I guess this patient has a relatively fortuitous name, but can we talk about the primary treatment, and then if there are any evidence-based alternatives to a specific treatment for syphilis?
Yeah, and so this is from the CDC, if you will. The efficacy of penicillin for the treatment of syphilis was well established through clinical experience even before the value of randomized controlled clinical trials was recognized. Therefore, nearly all the recommendations for the treatment of syphilis are based on opinions and persons knowledgeable about STDs. So we'll start with that. And the other one is so for Penny G, right? Penny G is pregnant. There is one treatment only. It's pretty simple. It's penicillin. And we'll talk about the slightly different versions of penicillin, but it is penicillin. And the reason for it is we know that it works, but we also know that other medications may not necessarily be ideal or have risk factors associated with their use during pregnancy. So let's step aside from Penny G for just a second. You said, what are some other evidence-based alternatives? You've got doxycycline, you have tetracycline, you have ceftriaxone, and these are other treatment options when you are not pregnant. And you might say, well, yes, but what if the person has horrible allergy to penicillin and they're pregnant? Oh, that's simple. You desensitize them and you give them penicillin. What if they anaphylaxis? Simple. Desensitize them and give them penicillin when it is pregnancy, because it works and you don't have to worry about some of the other side effects of those medications during that. And so, in a way, it's impressive, right? Penicillin's nearly 100 years old and it still has massive value. And I'll go on to the other one of, what evidence is there? I mean, you heard the evidence is all based on professional opinion. And I think that something you have to consider with alternatives to penicillin is if you're telling someone, hey, take this medication twice a day for 28 days, do you think that, and if you miss a dose, you're going to have to restart. Do you think that that's going to work all the time? And that's an issue that a lot of people are bringing up. And, it's what newer drugs do we have? There was actually a study that was recently done. I'm trying to remember. I think it was in Lancet. And they went, guys, we've got it. Linezolid. Let's do it. Let's go. Let's go. And they did it, and they stopped the study early because, nope, benzathine penicillin, it beat linezolid. And they stopped it because benzathine penicillin just worked. And so so that's where you say, hey, in pregnancy, it's penicillin, but you do have alternative forms of penicillin. You have injectable forms, you have IV forms, which we can talk about.
So one question I have, And one of the reasons why you're on the show is Avram here saw you give a fantastic syphilis talk at AAP. And during this recent AAP, I went to a talk on, I think it was updates in infectious disease or updates in antibiotics. And of course, the slide they show is with each bacteria, when they start an antibiotic, how soon that bacteria becomes resistant to it. And basically, it's like the scariest slide ever, because basically every bacteria becomes resistant to every antibiotic we use. And you just said that we've been using penicillin for syphilis for like a century. And the question is, why is it that way? Why is syphilis so easily treated by penicillin?
I mean, if you're gonna like take one and be like guys, we got lucky. this may be the one. Now I'll tell you why, and actually what makes it pretty hard. And again, right, back in the day when penicillin came around, it's like use it for everything, just funneling, because again, right, it was better than arsenic, it was better than mercury. I called mercury the meropenem of the Middle Ages, because anything, it was mercury. And believe it or not, I actually found a book that had the recommendations for dosing mercury. It was pretty interesting, how physicians would dose mercury. And so, I mean, in a way, I think it's luck. The MIC for Treponema pallidum to penicillin, I saw it sometime. It was like 0.0000000, some long. It's just, it works. And you might say, well, Ryan, here's the problem. It's going to get resistant. And so here's what we're going to do. We're going to take that Treponema pallidum. We're going to grow it up on agar plates, and we're going to do susceptibility testing. Yeah, here's the problem. You can't grow it. You can't grow it anywhere. There's actually one place that you can grow it, and it's placenta. And it's actually where it was first identified. Prior to 1905, it was believed to be a heritable condition. Some people said, oh, it's inherited from the father. And others like, no, it's inherited from the mother. And you're kind of like, sort of, but not exactly. Even to the point that Edward Munch had a painting called The Inheritance. And he drew a painting of a woman who had lost her child to congenital syphilis. And in the painting, the baby had the classic stigmata of congenital syphilis. It was called The Inheritance. But 1905, someone found it in a placenta. But here's the hard part. If you want to do susceptibility testing, you can't grow it. It doesn't grow anywhere. And the old rabbit infectivity test where you'd run down with your blood, well, we've got it. And you'd go down and there'd be a rabbit there who's pregnant, and you would inject into the rabbits to try to grow it into the placenta. And so why it isn't resistant, Lord, I don't know, but good luck trying to study it, because if you can't grow it, it's so hard to understand the mechanisms of resistance, and we can't grow it.
And so, we've been talking a lot about penicillin. I think we just should cover for our listeners kind of the treatment that we should be using. So, so what's the dose? How are we giving it? Do you give it IM? Do you give it IV? Do you give it PO? Why do you do the things that you do? And what should Penny G be getting?
Yeah, and so Penny G being pregnant, being this far along, one thing, and again, I'm assuming that she isn't coming in and she has clear signs of neurosyphilis, she's HIV, so there are certain things that would push you to maybe go a little bit further. But in a standard case of an individual like Penny G, and again, she told you, right? She told you that she's never had syphilis before. And so you can take that to the bank, and I say that slightly only because if we take it straight up here that this is a newly acquired early primary, because I don't see anything here about any symptoms of syphilis. Is she early latent? Is she early primary? Is she early secondary? I don't know. But if we say she is early primary, we picked her up before she manifested any symptoms, great. The treatment for her would be a single dose of benzathine penicillin. And this should be recorded. It should be reported. State health departments track this down and know that this is done. And I encourage people, document that you gave it. Because if you don't document that you gave it, then if you didn't, then when someone else comes back and finds Penny G's record and can't find that she got treated, what do you think they're going to do? Think that they need to treat her. And so important to document it. And it depends upon where you are, but when you ask most people about it, you're like, so tell me a little bit. And sometimes I do it not to play games with them, but I sometimes will find records that they have it done. So tell me about it. Was it just like a single thing that they gave you in the arm and they go, oh God, no. Oh God, it hurt. I had to bend over. They took it. They gave me 2 shots in each of my butt cheeks. It hurt forever. Oh my God. And then they made me come back and do it again. And they made me come back and do it again. I'm like, hey, you got benzathine penicillin. And it burns. But the crazy thing about benzathine penicillin is that it works. It's trapecidal for, about 21, maybe longer days. So you give that dose, it works for a long time. So for Penny G, in this case, if this is truly early primary, you have no concern that maybe she got it, 3 years ago, you would say single dose benzathine penicillin will follow your titers, make sure they come down. If however, Penny G came in and you start talking with her and she goes, ooh, hold on. You've been asking me all these questions, Ryan. Thank you. But I do remember, 3 years ago, I did have a rash on my hands, and no one knew what it was. They told me it was eczema, and it went away. I lost some hair. I had some swollen lymph nodes. In that scenario, you might go, "Ooh, hold on, Penny. Perhaps you had syphilis back then, and you could actually still have an elevated titer." And the reason why I make that point is because then, based upon that timing, you'd say she's late latent. And because she's late latent and she's pregnant, let's just do her right and give her 3 doses separated by a week. And this week thing is something that comes up a whole lot, which is, we're very like, it's got to be every 7 days. But you've noticed that this is moving a little bit. And it's the same thing even with rabies, post-exposure prophylaxis. It's got to be 0, 3, 7, 14. There's wiggle room. And so there's starting to be some wiggle room now on the 1 dose every 7 days. Some health departments are allowing 6 to 9 days. CDC, I think, moved 6 to 9 days on that, not every week. It's like, get within that window because, right, you don't want them to have to show up at the emergency room to get all their shots. That's not a good use of resources. But I will point out that the World Health Organization, actually, it's 14 days is what they allow it up to. So, it depends upon where you are. So know where you are when you're practicing. But Penny G, in this case, in this scenario, I think most people would probably go, oh, she has early primary or early secondary or maybe early latent syphilis. Single dose of benzathine penicillin. We'll track those titers and see how they do.
Awesome. And then, so we are going to talk a little bit about the algorithm, things like that when Penny delivers. So just hold on 1 second. But before we talk about that, if we do say, this was early syphilis, we gave her the single dose of benzathine penicillin. What is our essentially decrease in risk of transmission that we should be expecting after giving that full treatment?
Yeah. And so if this was truly early primary or early secondary, where the risk of the infant is actually higher, you can see that you can prevent upwards of 90% of cases that would be there with this single dose of benzathine penicillin. And again, it sounds, everyone thinks I'm so pedantic, and I don't want it to be that way. And I say that Sam, only because the important thing is when you sit there and you say, if you treat this mother, you will prevent congenital syphilis. And you might say, Brian, you're just being cynical. No, because I have seen this happen. I have seen the reason why I started a congenital syphilis clinic is because there was a similar similar case like this. Mom got treated. Everyone, well, mom got treated. The baby can't have it. And the baby actually had neurosyphilis with otic syphilis. Legitimately did. But because people are like, well, we treated, so the baby was treated. Not necessarily. So when I say that, I say, it can, in upwards of 90%, it does not get you out of evaluating that baby when you're done. But please give it. Because 90%, that's incredible. Like it really is incredible. Yeah. Numbers go down, of course, right? If Penny G were late latent, because the risk of transmission during late latent is just lower. So, how much is benzathine penicillin going to help? Hard to say because the risk of transmission is just a little bit lower.
Yeah. Related to risk of transmission, are there people who are at increased risk, either regional factors, and then, are there any sort of outcome differences for these people? Yeah.
And, I like to say, Texas, we're a leader in the field. And I say that slightly because there's a little bit, I want to say it might have been Franklin. It's bad that I'm drawing a blank on my quote, but the saying, there are lies, there are damn lies, and then there are statistics. And I bring that up because it does depend upon where you are. I was at ID week, and someone was like, "Oh man," he's like, "we've got more syphilis cases than anyone else, and in the strangest flex ever." I'm like, "No, you don't, bro. We do." And he's like, "Our rate is the highest." I was like, "Yes, but you deliver like 1/10 as many babies as we do." And so it's a couple of things. That question, who's at risk? When you look at different rates, the CDC has a wonderful graph of this, and really what it's showing is you, and if you do CDC, I'm trying to think of the best search term for it, but if you look, there's a graph that shows you on the left the percentage of live births in this country, and on the right the percentage of congenital syphilis cases. And what you notice is, you would think, if there's perfect equity about people who are at risk, these bars would just go straight across, right? If Caucasian or white Americans are responsible for 50% of all live births, they should be responsible for 50% of all congenital syphilis cases, right? That would numerically make everyone happy, but it's not that. So what you see, though, is you see that for Black or African American individuals, they make up about 14.5% of all live births in the US, but it's 29% of all congenital syphilis cases. Caucasian white, 50% of all births, about 26% of all congenital syphilis cases. So different risk factors, but one that often goes missing when you do the numbers and you crunch it, it's like making the comparative to the largest race of live births in the United States as white or Caucasian. If you compare African American to that, it's about 2.5 times higher risk. But if you look in the Alaskan Native or the American Native population, it's 8 times what it is. And good Lord, there are, you could probably do an entire podcast on reasons for this, but a lot of this is access to care, fractured healthcare systems. And so, when you say which groups are at risk, people are going to say, commercial sex workers or trafficked individuals. Yes, these are all individuals who are at risk, but when you look, there are also risk factors based upon ethnicity or race. And I forgot the other part of the question was the outcomes. I wish, and that's actually why I started my clinic, was because my interest was in outcomes and doing clinical informatics and trying to be pragmatic. My hope was to have huge, large amounts of outcomes by doing great case ascertainment for what these kids had gone through, and so that's why I focused on outcomes. And there just isn't much out there. The main outcomes are: did the infant die? Yes or no? Did the infant have signs or symptoms of syphilis? Yes or no? That's kind of it. How many are developmentally appropriate? No one knows.
Well, that's really helpful. Just if we may kind of move on towards when she goes ahead and delivers.
Let's be honest, keeping up with peds literature is hard. Over 1 million new articles hit PubMed every year, and only a handful really change how we care for kids. But if you missed a few articles that matter, it means missing out on better care for your patients. That's why we're into JournalFeed. JournalFeed.org is written by practicing pediatricians who scan the literature and send you quick, high-yield summaries of the most important peds and primary care articles right to your inbox every weekday. Each summary gives you the bottom line up front, the quote spoon feed, plus a super short, practical summary. You'll get smarter in just 2 to 3 minutes a day. It's fast, it's easy, and honestly, it's fun. And you can even earn CME credit. So, Cribsiders listeners, try JournalFeed free for 7 days and get 20% off your first year with code CRIB25 at journalfeed.org/Cribsiders. That's journalfeed.org/Cribsiders, code CRIB25.
So Penny delivers at 38 weeks. Her APGARs were 8 and 9. The baby had an uneventful immediate newborn period. The baby's RPR is 1 to 8. He doesn't have any sort of abnormal features on exam, any sort of stigmata, rash, rhinitis, hepatosplenomegaly, or jaundice. So just based on the history, where does this infant fall on the screening algorithm? And can you describe that algorithm, how we should move through that?
I absolutely will. And this is why people are probably like, he's a BS artist, because it completely depends. This child, I can make a case that this kid is proven or highly probable. I can make a case that it's possible. I can make a case that's less likely or that it's unlikely. And the reason for it goes back, I think, Sam, to your original question, like, how much do you expect that titer to come down? And this is another point of contention, but if you look, there was a paper in 2017 in sexually transmitted diseases, and they showed after treatment, 1 month after treatment, your titer should come down twofold. So 1 month after, Penny should have gone from 1 to 8 to 1 to 4. 3 months after treatment, about 90%, 3 months after treatment, about 90% of people had a 4-fold reduction. 6 months after treatment, 80% had an 8-fold reduction. So if Penny got treated at 10 weeks and she delivered, Penny's RPR better be low. So when you say that this infant's RPR is 1 to 8, and you want to say, well, where does the baby fall in the guideline? I need to know what mom's RPR was at delivery. Because if mom's RPR at delivery was 1 to 32, well, mom got reinfected, and we have a whole nother story. If mom's RPR was 1 to 1, when you look at the algorithm, the way in which, and this, I'll explain the way the algorithm starts. Up at the very top, it says, essentially, does mom have a history of syphilis? Yes, no. Okay, how did you determine that? Did you determine that starting with an RPR, or did you determine that starting with a treponemal test? But we know where we are, and then you get to a box and it says, evaluate mother's treatment response. So the way in which you're going to do that is with an RPR. And so if we just have the infant's RPR, this is why when you look at what the Red Book says and the CDC says, it says no child should be discharged from the hospital without determining what mother's RPR was. So let's say mom's RPR is 1 to 2. She had a pretty standard response to benzathine penicillin. Well, if mom's RPR is 1 to 2, then you look at this baby. This baby right here has a normal physical exam, okay? And mom was treated. Hold on. Mom was treated, great. Mom responded to treatment, great. Baby's physical exam is good. You're getting really close to a congenital syphilis less likely. Hold on. Baby's RPR is 4-fold or greater than mom's. Boom, you're proven or highly probable. Do not pass go. It's what it is. Now, another scenario. Mom got treated and mom went down to 1 to 4. Okay, so if mom went to 1 to 4, okay, that was not a very good response to treatment. Personally, I would have wanted to see a little bit more. So then you would say, well, okay, mom was 1 to 4. She didn't respond, didn't have a good response. Maybe you go back. No one ever asks. Mom, was your partner treated? No, they didn't want to get treated. Ugh. Are you concerned that maybe mom was reinfected? That's in the Red Book algorithm. And oh, okay, well, I would be. If you had syphilis and your partner didn't get treated, I'm concerned. And so then where you end up is you did your physical examination of this baby, but because of those concerns with mom's treatment and response to treatment, you then end up with this evaluate. And what evaluate means is you are looking for signs or symptoms that maybe this baby actually did get it. And this is where you'll see stuff where it says do a CBC, you're looking for anemia, you're looking for thrombocytopenia, you're looking for an elevated white count, and do a lumbar puncture. You're looking for elevated protein. You're looking for a VDRL in the CSF. The downside with everyone, and I get this all the time, oh, the VDRL was negative. Thank God. The protein was 600 and it was a champagne tap, but the VDRL was negative. The VDRL is like 40 to 50% sensitive. Not a great test. It just isn't. And that's why when you look at the CDC and you look at the Red Book, it says if the LP is abnormal. You might go, well, Ryan, it was a bloody tap. Pull up the guideline and do Control F, find bloody, and you'll see if it's a bloody tap, sorry, move on and go forth, and treat the kid as if it is. And you'll see other stuff thrown in there. Do an ophthalmologic exam, do a hearing screen, do a liver panel, do long bone films. That is part of the complete evaluation, because really what you're looking for is you're saying, does this baby actually have syphilis at all? And the reason why that makes a difference and where you'll get at the bottom of that algorithm is because if you end up in this less likely or possible realm, you can consider a single dose of benzathine penicillin. You can. And oh God, is that great. It's going to make everyone happy. You get out of the hospital on day 2. You don't have to put in a PIC. You don't have to do this. But the problem with it is when benzathine penicillin came out in 1954, it cost it was 8 pence and 5 shilling, and everyone loved it. And so do the math in your head. I can see you doing it, Eric. Do the math. It's by today's standard $11. So that's what it was. Everyone loved it. And across the board, everyone started changing their guidelines. Give benzathine. It's the greatest thing. It's just do it. The problem is about 10 to 15 years after that, someone went, hold on. Does it get in across the blood-brain barrier? And the answer is no. No, it does not. So if you have a baby who you're really concerned has syphilis and has an abnormal LP or the like, and you give benzathine penicillin, you are not treating the brain. That is where you then see the 10-day treatment coming in. Because when you have that scenario, so that's where you'll see that 10 days IV, where you switch the dose, where you switch the dose. And again, doses, look at Lexom, talk with your pharmacist, because if you're premature, it may change a little bit, but generally you're switching the dose around day 8 of life. It's like 50,000 units per kilo. It's Q12 and then it goes to Q8. But that's why there's that huge difference. And so it didn't used to be that way, but don't give a medication if you are worried about central nervous system. And so, when you look at this kid, it really depends upon what mom's RPR is. And so once you get that, it's going to help you decide. And I think I said, like, how could this kid actually be unlikely? How could this kid have been unlikely? Well, one way in which it could have been unlikely, right, is that if mom had she said she didn't have a history of syphilis, but you actually call up the health department and lo and behold, she was treated. And yes, guys, this does happen. People don't know that they were treated. And you look at this and you see that she had this 1 to 8, 1 to 8, 1 to 8, but at another lab, she was actually lower. You could argue, well, mom was treated. Maybe she was close to the serofast state and this baby's RPR is close to hers. Maybe it's unlikely. I say it only to highlight the point that it is so important to get all the history about about the pregnant people, and don't just take someone's word for it.
And for, we had commented on getting Penny G treated at 10 weeks. And so we have months with which to watch our penicillin G kind of start to actually work. And we should see, whether it be an 8-fold decrease by the time we deliver. If we did find this out at delivery instead of, or at 34 weeks or, whatever it may be, instead of 10 weeks, does your suspicion go way up because you just got a single dose of penicillin and you're like, this RPR ain't going to come down? Yeah.
Yeah. And so the more, to be honest, a lot of people do find out. Had a case, I think I did the case at AP, I did at ID week, which was someone actually had a prozone throughout pregnancy, right? So that whole, they have overwhelming syphilis, but their RPR is non-reactive. And so when they showed up at delivery, boom, they found out. And they found out because their RPR was 1 to 1024, so it was insanely high. But it brings up a good point. It's one that's tucked over there. You can see it in the guideline. Is this idea of, well, did mom get treated at least 30 days before delivery? So let's say that you're late to prenatal care, and all of a sudden you show up and you get this at 33 weeks, and this baby's born at 30. I forget when Penny G's baby was born, gestational age, but let's say it's 39 weeks. But when you found out at 33 and it was early primary and you started, where the language has changed a little bit, and it's interesting to say how the language changed, but as of now, the language is, did you start treatment at least 30 days before delivery? And so if it were a latent case, remember that's 3 weekly doses, but you started 30 days before. And so when you do that, there's still an opportunity for that kid to get classified into the less likely cohort, so long as they meet all the criteria, which is their RPR is not 4-fold or greater than mom's. They have a normal physical exam.
So just to summarize, this baby can fall in a lot of different areas based on mom's RPR. Mm-hmm. So if mom had a adequate response, the baby's RPR is now higher than we would call in a more likely category, rather than a less likely, unlikely, where the RPR is similar to mom's. Yeah. So at that point, you're either going down the pathway of evaluating for evidence of syphilis, treating with aqueous penicillin for 10 days. If entirely normal, the exam is normal, the RPR is not higher than mom's, then you go down the benzathine route.
You can go down
benzathine, and with ideally close follow-up. Is that a reasonable summary?
Perfect summary, and adding a little thing here.
Sure.
So if mom did respond appropriately, right? And we're really concerned because this baby's RPR is greater, fourfold or greater than mom's. In this scenario, the CDC and I need to look because they changed it recently. I don't think that they did it, but it's really the CDC is now saying this kid is probably going to get 10 days of penicillin, probably. So it begs the question, well, if you're going to do 10 days of penicillin, does it matter if you do the CBC and the long bone films and the LP? I mean, you do the LP and it's abnormal. Okay, I'm going to do 10 days. I was already going to do 10 days. So
It's true. It doesn't change treatment. Yeah.
Yeah. So
the intern does the tap.
Yeah, exactly. So you got to train on someone. No, and so this actually, I was approached by someone at ID Week, and I said, look, the mentor told me you'll only say no for yourself. Ryan also told me this. He goes, they're also just guidelines. They're not laws. They're not mandates. And so the thing that I will point out is, if I were to ask you all, if you had a baby who legitimately had neurosyphilis, do you think that is important to document for the future developmental screening of that child going forward? I'm seeing a lot of shaking heads.
100%. Yeah, I'll say that out loud.
Yeah.
I forgot this is an audio podcast.
Yeah. Versus if I say, well, look, I gave you 10 days, but I don't know. I mean, I was going to commit you to 10 days. And so, yes, it's an LP. I don't want to, if it were my kid, I'd be freaking out about it too. And people are like, oh my gosh, but legitimately, I've had hospitals call me and say, oh, the radiation from the x-rays. And I'm like, have you discussed air flight with the family? Because they will get exposed to 100 times the radiation. And so, right, a lot of people are looking for ways around it. And so it is a change. Like, I have to address that the CDC said this, but I do also say, what are you missing from? And the CDC does make a note. They're like, however, knowing this information may be of value. But the way in which I've interpreted this personally is the attending may go in and do the lumbar puncture and do and fail 4 times and you have a hematoma. And what I told them is like, guys, you don't need to go back, right? You've already committed. You're going to you gave it a try and that's fine, you know? But it's like, oh man, we have to get blood. I'm like, you already got blood. You did an RPR, you know? All babies get hearing screens. Like, so you do get quite a bit of the evaluation that is there. And so what I would say is this kid, you are absolutely right. If this kid goes down and he is in, you might say, oh, well, could he be possible? If the baby's RPR is greater than 4-fold or greater than mom's, he is not a possible. It is a proven or a highly probable. But I'm willing to give you a little bit of latitude here and say, if you do end up in that possible scenario, what I'll say is the guidelines and the CDC says it and the Red Book says it. It's like if every component of the evaluation is done and is normal, and most people don't do, and I track this in my clinic, most people don't do the entire evaluation. They really don't. And is normal, and follow-up is guaranteed, then you can consider a dose of benzathine penicillin. So, PAS 2024, a poster, lost to follow-up, 47 to 50%. Is that certain? Ryan, you run a dedicated clinic where all you do is track down people and get them in to see your clinic. My loss to follow-up is 20-ish%. And I'm sitting here patting myself on the back like I'm killing it. But is 20% a certainty? It's hard to say. Are there cases where there are possibles and we do a dose of benzathine penicillin? Yes. And I say, but you need to get in there. You need to talk with that family. Put me on the phone and I'll tell them why they need to follow up. And in those scenarios, you know what? They end up showing up because they're realizing that they're getting out of the hospital after like a day.
And that's honestly a perfect segue to actually talk about follow-up, right? Why is it important to follow up? When are you following up? What tests are you repeating? That type of thing. Let's just take Penny G's baby as on the lower likelihood scale. It will just say that Penny G ended up having still RPR was 1 to 8 or something like that because it was late, whatever it may be. And so this baby got a single dose of penicillin G and got discharged because they knew they had great follow-up with you.
Yeah.
When are you seeing this kid for follow-up and what tests are you repeating and when?
Great question. And what I will add one thing that we didn't add about, because I do see this a lot and I think it's super important to highlight. When we tested Penny G's baby, we did an RPR. A lot of places they'll send their syphilis test. But what is their syphilis test? Oh, it does a treponemal antibody. Oh, but remember, the treponemal antibody is confirmatory. If it is positive, this person has syphilis. That's what it is. Unless it's a baby, because that antibody will cross the placenta and it will remain in the baby for 18 months. So when we talk about this and you look at this and you see those positive tests, I've had many people with a non-reactive RPR and a positive treponemal antibody, and they lose their minds. It's confusing. So don't look. There are scenarios where someone like me will send the treponemal test sometimes. Just don't make a habit of it, or talk to an ID doctor before you send it. But for following up for this kid, where I try to target, where I try to target is 2, 4, and 6 months of follow-up for someone who's in the highly probable, the possible, or the less likely. What the Red Book says is all infants who have reactive serologic tests for syphilis or were born to a person who had evidence of syphilis should receive careful follow-up examinations during child care visits at 2, 4, 6, and 12 months of age. Okay, cool. And right, makes perfect. They should be going to the 2, 4, 6, 9, and 12 month follow-ups anyway. But this is where you're like, well, then what are you doing, Ryan? Like, why are you seeing them? Well, because when I looked at how often this is happening, when you go through and you look at the discharge paperwork, and it was great. I had an intern with me today, and she's like, she went through all the discharge paperwork, and she's like, there's nothing in there about syphilis. I'm like, yep. So what do you think's going to happen when that kid shows up at the primary care provider? Do you think that they're going to get into Epic and get the care everywhere and do some weird informatics stuff to get all the No, they're not. They're going to go, oh, thank God. They told them, don't shake baby, put baby in a car seat and do this. Great. There's nothing wrong with this baby. So my cynical concern was, these infants all go and see a pediatrician. The pediatrician does not know anything, because people don't kick down the door and go, hey, doc, I had syphilis. They don't. And so really, were these infants getting the true evaluation follow-up that they need? Probably not. And when I looked at our numbers within the Texas area, I saw that an infant who was born, I'm working to publish this, it's just whenever I have time to do it, an infant who was born with a positive RPR in an infant, only got that followed up about 47% of the time. That ain't good. And that tells you education's a huge thing. And so when I did my clinic, the reason for the 2, 4, and 6 is largely because you're looking to make sure that RPR is coming down, and you're looking to make sure, because again, it's a probability. Now, you could say, well, look, if you funneled the kid full of 10 days of penicillin, are you going to do anything? Probably not, but you try to make sure you educate the family a little bit. You talk with them. I'll give you a little hint of that here in a second, but you're just making sure that the kid's also developing appropriately. However, if you just did a dose of benzathine penicillin, you did not treat neurosyphilis. So you're making sure that you treated that appropriately. And a lot of times, you probably did. But what scares people is if you go and you Google and you say, baby congenital syphilis, one of the most common findings that you see is a runny nose. Oh, thank God we don't make things called nose Fridas, because babies have so many runny noses. I cannot tell you, rash, this, Osler never called it, but the Great Imitator. So families, and the reason why I see these families at 2, 4, and 6 is I try to tell them, look, we are looking for syphilis in your child. So don't go out and look at the clouds in the sky and see something that's there, because if you put in what you think your baby has and type syphilis, you'll find it. But that's why we're checking your RPR, and that's why we treated you. And so that's why I do like a 2, 4, and 6 is to help educate them, walk them through it. But once you get to 6 months of age, that RPR better be non-reactive. If it isn't non-reactive, they're coming into the hospital and you're redoing the whole thing. And again,
you could treat them.
You would reevaluate, or you'd reevaluate or just commit them. And I've had that happen about 3 times since I've had my clinic. And you're upfront with it. It's like, and most families are actually pretty willing and accepting them. It's like, look, when you got treated, did they say, oh, we treated you, don't ever come back and don't ever get this test repeated? No, they said you need to come back and get it repeated. And that's exactly what we're doing. And the reason for the 2, 4, and 6 is because of concerns about incubating congenital syphilis that can take up to 3 months. But also when you look at test performance, this is what's crazy. If I got syphilis today and I ran to the lab and got tested, I'd probably test negative. And after 8 weeks after having gotten it, if you test me, about 50%, and this is an old paper from the early 2000s, if you were to test me at about 8 weeks after having gotten it, 50% of the time I'll test positive. So if you test that baby at 2 months and they're negative, you don't know. So this is why you'll see that drag out. And, maybe one day we'll get to where pediatricians are doing all this in their clinics. But when I saw this huge gap of it not happening, I just got concerned. And I'm like, look, we can be philosophical and assume education works, or just set up a clinic and do it.
I do have more questions about kind of the follow-up piece. One of the things that you're talking about is that we are trying to make sure that, we're the ones who are looking for syphilis when we see you in these visits. We did talk about this because it's a screening algorithm. We really caught Penny G when she was pregnant, but we haven't really talked about what does congenital syphilis look like. So what are we looking for when we're the doctor that's coming to see them? And so like, what is the classic textbook presentation for congenital syphilis that we're looking out for? Numbers wise, nothing. And
Great. no. Hey, well, and like I sound so awful, but if you go through and you say, okay, and again, it's not just me. And what's really actually fantastically amazing about this is when you look at this and you say, well, yeah, but maybe it looks like this. Maybe it looks like this now because we have all these medications, we have all this treatment. In Osler's one of his first books in 1899, he essentially went through and even made the point that look, kids with congenital syphilis can have all of these different things, but most of them are born asymptomatic. They really are. And so, right, I'm not asking for people to go looking for it, but the other non-classic signs are a large liver. So. And again, oh my gosh, a large liver, they have congenital syphilis. Well, no, I mean, it's not very specific, but it's there. So you're looking for that. You're also looking for bullous or exudative lesions. So a great case that I always present was a child who showed up, and this kid was missed. It wasn't a Penny G scenario. This kid, no one checked mom's RPR before the baby was sent home. And this baby showed up with hair loss and a peeling rash on their hands. And they're great pictures, actually, of like them holding the baby's hand up for a picture without gloves. And it's like, oh God, you have to go home and tell your family you got syphilis from a baby. But what was interesting about it is like this kid was dying, had this crazy rash, hair loss, and like a lot of bone pain, and was diagnosed with acrodermatitis enteropathica because they were having failure to thrive and hair loss because of inappropriate formula mixing. That's what it was called. The problem was the kid actually just had syphilis. That's what it was. And the minute they funneled penicillin into this kid, everything improved. Everything went away. And so, rashes, and they're more exudative or bullous lesions, but they can even just be those typical small little rashes that you see in secondary syphilis that look, honest to God, pretty innocuous. Meningitis, osteitis, thrombocytopenia, anemia, pneumonia is another one, and then like the syphilitic sniffles. And so, those are things, but it's so hard, right? When you say you need to look out for a baby with a runny nose. Really? They all are. But a runny nose and a peeling desquamating rash and hair loss. And here's the thing. I've seen that be passed. I've seen babies where they go, it's something else. It's not. So those are the big things. And again, I think the paper I was saying before where when I was talking about the doctor who's complaining that people just haven't seen cases of congenital syphilis in practice because they didn't train under it, he said perhaps people should just always think syphilis to some extent. What I tell people, and I tell families, and I tell providers is we're thinking, like in clinic, we're thinking syphilis. We are. And that's why we're doing an RPR. And if you have that runny nose and your RPR has gone completely away and you got benzathine penicillin, it's not syphilis. It's just not.
And that's, I mean, obviously it's way easier when you know mom's screen positive. You make sure that you're looking for these things and going to associate them with an RPR versus if you're a regular primary care doctor and a patient comes in, you have no idea what the maternal history is, but you just have 15 minutes and that's just going to be challenging.
And it's going to be so challenging. This is for education. When I try, as I say, look, if you're a NICU provider and you know this, please tell the family you need to follow up with your primary care provider. You know, Eugene Brieux, a French playwright, wrote a play in 1901 called Les Aviaries. And then in like the beginning of the play, you know, it was a scene and essentially he said, you know, syphilis is a disease like all other, and like all other diseases, it's a misfortune, but there should be no shame in being misfortunate. And you know, it's great. They're actually old posters. You can go and find them if you look at Library of Congress, but there are old posters from the 30s, late 30s and early 40s that said, shame may destroy your health. Do not let false shame, you know, give you an early grave and stuff like that. And so I really try to tell NICU providers who are delivering the babies, but it's not just that. You also have midwives. You have a huge audience. Pass along the information and let the family know, hey, it's important that your provider also follow up on this. And then let's say your primary provider. I mean, we have people all the time where it's like, John is an 18-year-old male born to a GBS positive mother. Like everyone loves to find the GBS positive and put it in there. Maybe like if you're in an area where you have high rates, maybe look for that information because it should be there because people are screened at birth.
Awesome. I will say I have one final question from this from this section, and then we will likely wrap up this section in a second. The actual treatment, you know, we talk about giving penicillin, we talk about killing spirochetes. Mm-hmm. When we kill spirochetes, we tend to have certain types of reactions that we see in people. Would you mind kind of walking us through what we might see in adults versus what we might see? So what we might see for Penny G versus what we might see for her baby, or do we never see these type of reactions in babies?
Don't really see, probably in the baby, what you're going to see is the baby's just getting better. If you can even perceive that, you know, a lot of the cutaneous manifestations, lab abnormalities, those are going to improve. Hearing's a little bit different. You know, it's uncommon. I've actually caught 2 kids. You know, hearing loss with congenital syphilis is classically, it's a late congenital syphilis. You know, it's the Hutchinson's teeth and the palatal perforation. I've actually had 2 kids who were legit. We ruled out any haters out there. We ruled out other causes of hearing loss. And so, you know, in those cases, you might say, well, do you see improvement in the hearing? We hadn't in these 2 kids, but the kids' rash, the other things, yeah, we see improvements. Now, in adults, what you can see, and I think I had alluded to that, you know, that one case of that woman who had the prozone phenomenon where she was screened early in pregnancy and she was non-reactive. What I left out, and when she delivered, she was 1 to 10/24. What I left out in the middle was that she showed up at her provider and she had a painless genital lesion. And she had this painless genital lesion and they swabbed it for HSV and it was negative. And they're like, oh, it's a staph infection. So they actually started treating her with high doses of amoxicillin, which is, you know, amoxicillin is not one of the classic trapecidals because no one's ever studied it, but people are talking about studying amoxicillin. After taking a dose of a huge slug of amoxicillin, she started having a headache, a fever, and she started to break out in a rash on her palms and on her soles. And she was told that she had a penicillin allergy and to stop the amoxicillin. But she didn't. She just had probably, in the term is the Jerick-Hersheimer reaction. It's probably what she had. So that's kind of the classic, almost like, you think about with some infectious diseases when you treat like a huge burden of disease, or you treat like a huge worm burden, you get like this huge inflammatory response. That's what the Jerick-Hersheimer reaction is. But to be honest, I personally, that's the only one that I have seen. Classically, when you read about it, they mentioned it was like as many as 40 to 50% of people have a Jerick-Hersheimer reaction. Maybe people aren't talking about it. I'm not sure, but you do see those reactions more with, you see those reactions more with like the early primary, early secondary. But in general, the main reaction you're going to have is people are going to complain, oh God, that hurts. And it hurts to walk. And that's going to be one that you hear a whole lot about.
So while that might be a feared, maybe not complication, but a feared effect of treating syphilis, I mean, the risk benefit, obviously far outweighs that.
Oh yeah.
So you still may counsel the patient on that as a possible effect
Yeah.
of treatment.
Yeah. And it's like, and for me, I guess, generally most of my patients I talk to, they never talk back because they're 2 months old. But, occasionally I'll get an adolescent come through the clinic. I'll tell them, like, look, compared to every other thing that is associated with this, you can have a one and done. And even if you break out with this, it's uncommon, it's a thing. But I mean, so are so many of the other medications that we use. And I tell them that, I'm like, look, there are a lot of antibiotics that have other reactions as well. But I've never seen it. I'm trying to think how many adolescents I've actually treated. It's less than 100. So definitely not the master of it, but I've yet to see it happen once. But I still generally convince people, hey, it's worth it. Get the shot.
Well, Ryan, thank you so much. We have learned so much about congenital syphilis today. I really appreciate everything you've done for us, educated me, especially helping us understand diagnosis and management. As we get close to wrapping up, is there any other things you want to make sure that our listeners know about congenital syphilis before we go?
Yeah, and I think a hard part that makes a little bit about this talk esoteric. It's like, I don't order the RPRs. What's treponema? What's this? It's confusing. And you might say, well, I'm not even the one delivering the baby, or I'm not the primary provider. And, I was, when I was recently talking at ID Week, I was sitting there, I was like, man, how do I make this relatable to everyone? I don't want to just be sitting there in my own chamber of talking to ID doctors. And so I turned back, I've mentioned history a little bit throughout the show already. And so there was a physician, mid-19th century, his name was Prosper Yverin. He was a syphilologist of the time. Yes, that was a term. Maybe it's coming back. Maybe we'll have syphilology as a lecture series. But what he said when he was talking about syphilis in general is he said, it's not just the responsibility of statesmen, public health officials, and economists to study syphilis, to combat it, and to make its elimination their crowning glory. The whole of society must unite its efforts to wipe out this great destroyer. And then he goes on to say, on the contrary, we dare not even pronounce its name. Even practitioners of the medical art themselves have been reduced to disguising the thing behind euphemistic circumlocutions. And circumlocutions, you might have to break out, the old SAT book to figure out, exactly what that was or what that meant. But really what it means is people are starting to talk around what it is, as opposed to saying, oh, you tested positive for syphilis. Let me tell you a little bit about syphilis. And you might say, well, yeah, but okay, that was a guy from the 1850s. However, another syphilologist actually from the mid 20th century this time around, his name was Paul O'Leary. In the foreword for a book, the book was called Corky the Killer. Someone gave it to me. It's the story of syphilis written in 1940. But in it, he said, the stigma of immorality and indecency implied by the word kept many people from acquiring a desire to learn much about it. And he goes on to say that secrecy of the disease had been due in great measure to previous conservatism of the medical profession in failing to familiarize people with the facts, rather than indifference of the reading public. So the point here is, how do we expect our patients to know about this if we aren't going to talk to them about it? And so that's why I think it's important for OB-GYNs who are listening. When you're screening, you need to be passing that information on in your notes. You know how many times it doesn't show up in notes? I see this a lot. Or even handoff with a neonatologist who maybe shows up for the delivery, and the neonatologist who's writing their discharge paperwork, or talking to the family to talk to the PCP. It is a network that needs to be there. And I just think it's really important. And the one thing I've really found myself saying is, we talked a lot about the guidelines, and people love guidelines. They're great. They really are. But what I often hear is I hear people say, Ryan, but I looked and it's not in the guideline. It's not in the algorithm. I always tell them, the answer that you want to hear is not in the algorithm. The answer that you need to hear, however, is. And that's because people will dance around, and they'll dance around and find a way in which, oh, well, the test was done at a different lab and it was here and it was this. And, it brings me back, there was a quote by another syphilologist, and this was like the early 1900s. His name is John Stokes, and he said, there are instances where one positive Wassermann test will convict a laborer over his own denial. Two will make a case against a banker, or or a railroad president, but 3 successive positives will scarcely convince the physician of the guilt of a clergyman. And so, all right, and the point is right, people will use the test to tell them whatever it is that they want to see. And when you talk about a disease that really is stigmatized as it is, people then will use the test to go, oh, a person of this race, sex, or creed does not have it, but one of this, they do. And I just don't think that that's right. The tests are there. Let's follow them, So, and go on, but it's stuff like that I think is an interesting, is an interesting way to think about it. And the reason why I turn back to history quite a bit whenever I'm doing this is because I think a lot of times we sit here and we're like, man, this is all new, man. We're going through this new thing we haven't gone through before. Man, we've been going through this for 500 years and we're fighting the same battles we've been fighting for for over 100 years. And what I'll say is probably the last one, the last little leaving bit of evidence comes here from, Eugene Brieux, that French playwright that I spoke about, the one who said, you shouldn't stigmatize syphilis. He said at the beginning of his play, I think syphilis will be considerably less serious when people dare to speak openly of a disease which is neither shameful nor a punishment, and when people are more aware of the duties they have towards others and towards themselves. And that was in 1901. It was before penicillin was even discovered, before we were even giving these patients arsenic. That was the perspective of an individual who had been in and with this population.
Yeah, I mean that's absolutely fantastic. I think that applies to syphilis. That applies to a lot of things. We always want to do what we think we want to do, but not always what's right. So I think that's going to be a great take home point, for all of us anyway.
Thank you, Ryan. We really appreciate you telling us a lot and learning, honestly, a lot about history today. Right before we go, can you give us some pointed take-home points for our listeners before we go? Yeah,
and so I'll say just I do hear a lot, really? Congenital syphilis? Really? This is your life now? And again, look out and look. And I think despite our best intentions, and I really think that people have our best intentions, congenital syphilis rates are skyrocketing in the U.S. And we didn't talk about the numbers, but simple numbers here: about 300 cases in 2013, almost 4,000 cases last year. Wow. In Texas, where I am, 70 cases in all of Texas in 2014, and almost 1,000 cases in 2023. These rates are going up. And so I think a lot of people assume, if they had congenital syphilis, someone would have told me. And I think we really do assume that these kids are followed up. But if you look at the data, I think it would suggest otherwise. Going back to what Prosper Yverin said, it's on everyone to try to eradicate this, make this their crowning glory. And if there's one really practical thing, all children born to mothers with a history of syphilis need repeat testing after the neonatal period when the mother is seroreactive. And people will go back and forth about, well, how often and what frequency. Having the conversation is so important, because if you aren't talking about whether or not you need to be sending RPR, you're probably not thinking about it in an individual who is born to someone with a history of syphilis. And then the final one, hey, my email's probably out there somewhere. Send me a question. Don't be a stranger. I get stuff all the time. If you have a question, shoot me something. I don't mind, I don't mind answering, because it is confusing. But remember, there are colleagues out there who are as passionate as I am about this. And I'm pretty sure that they're just waiting for someone to reach out to help them.
Awesome. Well, I think one of these days in the future, we're going to have you come back, because we still have so many more questions to talking about how to treat our adolescents with syphilis, maybe the history of malaria therapy, a little bit more about policy. There's so many more questions about syphilis I think we have, so we definitely have to have you back.
I'd love to. Thanks.
This has been another episode of the Cribsiders.
It's for the kids!
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter at our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Dr. Avram Rago, and our wonderful social media team on Twitter and Instagram. I've been Sam Mazer.
This has been Avram Rago.
And this has been Chris the Chu Manchu. Thank you, and good night. And for those who've made it all the way to the end, I have another poem written by AI. It's titled Silent Shadows. In the quiet corners where shadows lurk deep, a whisper of an old in silence does creep. Syphilis, a specter from days long past, finds its way to the young, a shadow it casts. Tiny hearts and bodies so fragile and new, bearing a burden that's hidden from view. Passed from warm embrace to innocent sigh, a tale of transmission where hidden dangers lie. Armed with the lantern of the modern day lore, healers shine light on this darkness once more. With tests that confound, often hard to discern, they seek clear answers at each twist and turn. Penicillin, the knight in this age-old fight, charges forth to banish the blight. From the first faint signs to cure in sight, healers battle armed with might. In labs where results weave a complex web, a path to diagnose is often a trek. Yet, with care and precision, the truth is found. In each confirmed case, hope is unbound. Families gather, hopeful and strong, in clinics where healers work right the wrong. With compassion and science hand in hand, together they stand, a committed band. With each victory small in whispers of health, lies the promise of life, the truest wealth. For the shadows may gather, but the light finds a way in the heart of the clinic where the children play.